Hi, everybody. My name is Elena Byhoff. I'm one of the second-year RWJ clinical scholars, and I'm honored to be introducing Paula Lantz, our speaker today. Paula Lantz is a professor of public policy and health policy and management, and also the associate dean for research and policy engagement at the Ford School. As a social demographer and social epidemiologist, Professor Lantz conducts policy-oriented research regarding the social determinants of health and health disparities over the life course. She recently received an award from the Robert Wood Johnson Foundation to start a transdisciplinary research center on population health policy, which includes research projects regarding social impact bonds, government health and all policy strategies, and interventions regarding the medical and social needs of superutilizer patients. She's an elected member of the National Academy of Medicine. She just returned to Ann Arbor after several years as the chair of the Department of Health Policy and Management at the Milken Institute School of Public Health at George Washington University, and we are delighted to have her back at U of M and speak with us today. So, Professor Lantz.
Thank you.
Welcome back.
Thanks. Hello. Since I have returned to Ann Arbor, several people have asked me, can you really go home? And the answer is yes, you can. So I'm happy to be home in Ann Arbor for sure. So thanks for coming out this afternoon. I want to start by acknowledging my co-conspirators in this research, Doug Evans and Holly Mead at George Washington University, and Carmen Alvarez actually was a postdoc working with us who got her Ph.D. in nursing from the University of Michigan, and she's now an assistant professor at Johns Hopkins. And then Lisa Stewart, who is a patient advocate, joined our research team, no nonsense, non-researcher on the research team, which was awesome to have her and her voice in there. And our funding was from the Patient-Centered Outcomes Research Institute, PCORI, you've heard of it, right? We actually got one of the first pilot awards, the first round of awards that they gave, which they called pilot awards. Our award was about $600,000, so I never heard of a pilot that was sort of that generous, but we're lucky to be funded through PCORI. And our focus in this project was in one area where we actually might worry about the overuse of healthcare services. And there's a lot of attention to this issue right now, in particular the Choosing Wisely campaign, and many of you are probably familiar with that. There's a lot of interventions going on as well, and some of these interventions where, again, we're worried about the overuse of different kinds of services. The interventions can focus on systems, clinician interventions, patient interventions, or the general public. Our particular focus on this more general problem, if you will, about potential overuse of healthcare services was in the area of clinical preventive services. And as background, as I'm sure you all know, you've heard of this thing called the Affordable Care Act, right? And one part of the Affordable Care Act is that several kinds of health insurance plans, as listed here, traditional Medicaid, Medicare, and non-grandfathered private plans, must provide coverage and prohibit cost sharing, meaning there's no co-pays, no application of deductibles to certain kinds of clinical preventive services. And here we have to give a shout out to VBID for, again, this concept of if you want to incentivize the right kind of care, you know, get rid of those co-pays, get rid of those applications to deductibles, and try to move the needle that way. So thank you to VBID for that. But again, in this particular part of the Affordable Care Act, again, the focus is on clinical preventive services, and there's now no cost sharing for items or services that get an A or B rating from the U.S. Preventive Services Task Force. And then some other things as well, immunizations that are recommended by the Advisory Committee on Immunization Practices, which comes out of CDC and some other areas. We were really focused on the U.S. Preventive Services Task Force, this evidence-based task force that does give ratings to clinical preventive services. Some people, you know, have colloquially referred to it as sort of the Bible of clinical preventive services. Getting it into the Affordable Care Act has sort of really elevated the status of the U.S. Preventive Services Task Force, and I think we're still trying to figure out sort of what that means for the task force and the use of clinical preventive services, and hopefully at the end we'll have time to maybe talk about, you know, the task force itself a little bit more. Clinical preventive services are a kind of healthcare that we can call preference-sensitive care. It's not like, a patient-clinician relationship is one that we usually say is a principal-agent sort of relationship. The patient is often relying on the wisdom, the agency, the experience, the knowledge of that clinician to help them figure out what they should do. And when we think about shared decision-making, it kind of depends on what kind of care you're talking about. If it's cancer treatment or some, response to very serious rare disease, of course, the patient is really going to be listening to the doctor and trying to, figure out what the options are, but often sort of saying, and I know how many of you are clinicians in here, patients say, what would you do, doc? What should I do? All the time, right? And of course that happens with clinical preventive services as well, but this is not treatment. So again, we sort of think of this as a kind of healthcare where certainly if there's any kind of healthcare where patient preferences should matter, that was hard to say, it's definitely in this realm. It should matter what a patient thinks about getting a kind of health care that they don't need to treat any kind of illness or condition. And so this is exactly pulled from our grant application to PCORI with the enhanced role of the Preventive Services Task Force in healthcare reform and insurance benefit design. It's important that patients understand how evidence-based guidelines are developed, and also that patients and providers be able to communicate effectively about these guidelines. And we also think that it's important for all guidelines, but it's really important when the guidelines are recommending against getting some service. And especially if the guidelines have changed over time. So think about mammography for women in their 40s, PSA screening, the frequency with which women should get Pap tests. When these guidelines change, it does cause a lot of confusion and uncertainty. So our premise, again, is patient-centered, informed preventive care requires an understanding of the purpose, process, and results of evidence-based guidelines and how patients or consumers might interpret and use them for personal care decisions. So our study, or award that we got from PCORI, had 3 aims. Here's the first one. We wanted to explore, kind of do some formative research looking at knowledge and attitudes of the Preventive Services Task Force, using focus group with patients, but also here we talked to 175 different primary care providers. And here we used what I'll refer to as the Stephen Katz method of doing this really quickly. Years ago, I worked on a project with Stephen where what we actually did was rent a booth at professional clinician conferences and handed out boxes of chocolate as people walked by and say, hey, do you have 10 minutes to talk to us, and have not fill out a survey, but have a short, again, semi-structured sort of conversation. So we're not going to try to publish from this. This is not a representative sample. It's the people at the family physician conference and an internal medicine conference and other people who wanted chocolate. Some guy sent his wife back, who's not a doc, for more chocolate, and I busted them because she didn't know what she was talking about. Some guy tried to steal more chocolate. I just slap his hand. So people are motivated by chocolate. But anyway, I'm gonna be talking about the other 2 aspects of our study. That work was very informative to what we did in these other parts. And one was a population-based survey. And that's about to be published in the Milbank Quarterly. And then the third part is actually an internet-based experiment where we randomly expose people to different kinds of messages about clinical preventive services, and that was recently published in Social Science and Medicine and Population Health. So for any of you who have funding from PCORI or are thinking about going there, it's really important to PCORI that patients are involved with every part of your research. Again, they do need to be part of your research team, and we certainly did that. So the survey. Our purpose here was to conduct, because this hadn't been done before. So what do people in the US, what do they know about clinical preventive services? What do they know about coverage, insurance coverage for it? What do they understand about this thing that a lot of us just say every day, evidence-based guidelines? What do they know about guidelines or evidence-based guidelines? the Preventive Services Task Force. And then in the survey, we were really sort of focusing in on the Preventive Services Task Force recommendations regarding mammography screening and PSA screening. So our survey methods here, we used the GfK Knowledge Panel. GfK used to be called Knowledge Networks, a company. They were bought by a Danish company. I can't say what GfK stands for. It's a very, very long name, but they go by GfK, and this is a nationally representative panel, survey panel. A lot of researchers, so there's all kinds of online survey panels out there now. A lot of researchers really like to use GfK because their sampling process really does try to make it representative of the US non-institutionalized population. So they start with a sampling frame of post office addresses, randomly pick those. If they pick people, they basically go to people and say, hey, will you be in our survey panel for 3 months? We'll pay you if you answer, and some of their work is market research and some is, again, more academic kinds of stuff. But they'll pay people to be in their panel for 3 months. If someone says, I don't have internet at home, I don't have a computer, they actually provide that to them free of charge for the length of time that they're in the panel, which it typically is 3 to 4 months. So our target sample here was, we wanted a sample of 2,500 adults. We had an oversample of African Americans, Hispanics, and people with less than a high school education. So GfK put the survey into the field. You can't really talk about response rates because they'll actually put the survey out to a few more people than you want. And our sample size calculation said we needed 2,500 people. They put it out to maybe like 2,800, and then once you get to your number, then they sort of stop enrollment. We offered this survey to people in either English or Spanish. About 8% of people preferred to take the survey in Spanish. And when weighted, so there you have to have different sort of survey weights for the sample selection, the non-response, or oversampling, et cetera. But when weighted, the survey data do represent the US non-institutionalized population, or so we say. All right, so some really just basic descriptive sort of stuff here. So of US adults, 18 and over, about 20% sort of said, yeah, I know what, have you heard of a kind of healthcare called clinical preventive services? If you just say that to people, only like 1 in 5 are like, I know what you're talking about. I mean, once you then give them a definition of it, and say it's things like, getting your teeth cleaned by the dentist, getting immunizations, then more people sort of go, aha, now I get it. But if you just use that term, clinical preventive services, and that's jargon, so a lot of people don't know what it is. And then if sort of we'll rate your knowledge of it, fewer people actually would say, I really understand this. I have excellent, very good, or good knowledge. Now, a little over a third of people actually said they knew that the Affordable Care Act now said that insurance companies have to cover clinical preventive, they don't know what clinical preventive services are, but they know the ACA says that their insurance plan has to cover it. Have you heard of the US Preventive Services Task Force? I've been talking about this a lot lately, and I usually ask audiences, what percent of the US population do you think has heard of the US Preventive Services Task Force? And most people answer in a single digit. Is that what you were thinking? Probably less than 10%, so here's what we are. Once they have a description of it, it was short, low reading level description of what it is only, and then say, would you trust the decisions that are made by this? Admitting that it's a government-sponsored activity, only about a third of US adults say they actually trust such a body to make good decisions. All right, so since the Preventive Services Task Force is a process that really values evidence, it's an evidence-based determination of what clinical preventive services should be recommended or not, we asked the survey respondents a number of questions that had to do with, sort of the role of research in creating guidelines and what insurance companies might cover, how their providers should act. So here, providers should follow guidelines for clinical preventive services. About half of the respondents either strongly agreed or agreed with that statement. The rest were neutral, your typical 5-point Likert scale, right? So they're neutral, or they disagreed or strongly disagreed with that. Research is important for making guidelines about clinical preventive services, about half. Again, the U.S. Preventive Services would make FAIR guidelines, about a third. Government guidelines are used for rationing healthcare, about 40%. Not surprising, but we actually, and we say that a lot. I mean, people are worried about rationing, so here's sort of what the magnitude of this was a couple years ago anyway. Insurance should only cover a clinical preventive service if a guideline recommends that service. Only 1 in 5. See other reasons for insurance to cover things. So that was the basic descriptive sort of stuff. So of course we did a lot of multivariable regression to try to figure out, so who holds, certain positive versus more negative opinions. And we had lots of attitudinal variables, and I have to say there's nothing more dissatisfying than running a ton of regressions and not having very many things, come out significant. It's sort of like, it's hard to predict. So, I mean, there are very few things that sort of bubble up and they're not all that surprising. So insurance should have first dollar coverage for clinical preventive services only if guidelines recommend it. People who are older, so these are odds ratios compared to, in this case, people who are 18 to 30 years old. These are statistically significant. So people are more likely as they get older to agree with that statement, and as people move into higher education attainment groups, they're more likely to concur with that statement. And Hispanics, actually, compared to whites, were more likely to agree with that statement. Research is most important for making guidelines about clinical preventive services. None of the sociodemographic variables we looked at were related to that except for education. It's important for healthcare providers to follow guidelines. And again, not everyone sort of agreed with that statement, but people who were a bit older and then people with some college were more likely to agree with that as well. Now we did, I should say that in the survey, we gave an explanation of what guidelines are and gave a lot of examples of what guidelines are. And then we asked 2 different sets of questions. First was, how important is X? So these sorts of things. How important are these things in creating guidelines for clinical preventive services? Now here though, lots of people, so the vast majority of people either said scientific evidence is very important or somewhat important. So here we're sort of getting a different sort of sense of, the country actually isn't full of Luddites. They kind of think that science and research is important. How important is the opinion of medical experts in creating guidelines for clinical preventive services? And again, the vast majority of people if the costs are worth the benefits, about 80% said, yep, that would be important. Recommendations from professional societies, we gave them examples of what that might be. Professional standards of care, you see, as we go down the list, we're getting lower and lower sort of agreement with that. The opinions of government experts, we said, like the Surgeon General or the head of the Centers for Disease Control and Prevention. How much it should cost patients, so before they said, yeah, the costs and benefits should be looked at, but how much it costs patients should not go into recommendations. And then political motivations, lawyers do not come out well here. And we asked some other questions related to that as well. And again, we asked people, here's where the 2-set question came in. We asked people, who do you think is involved with making guidelines for clinical preventive services, and who would you trust doing it? And although only 15% of adults believe that patients or consumers were actually involved with making guidelines, 41% reported that they would trust their involvement. And we know there's a movement in this country towards patient engagement. I mean, that's what PCORI is all about, too, about patient-centered care and patient engagement. So that wasn't particularly surprising. 43% of US adults believe that insurance plans are involved with making guidelines for the use of clinical preventive services, but not that many people trust their involvement. And again, low levels of trust for other groups. I have to say we asked them about university professors. They were kind of in the lower middle of who they trusted. They trust physicians and nurses. I mean, they trust, medical clinicians, but other kinds of researchers, not so much. It's okay, I've lived with this my whole career. But low levels of trust, obviously, for pharmaceutical companies, economists, legislators, and those lawyers always come in last. All right, so now I'm going to show you, in the survey, we actually presented the respondents with a couple of vignettes, and everyone answered both. So one's a vignette about a man and PSA testing, the other's a vignette about a woman and mammography screening. But everyone answered, both men and women, read both vignettes and responded to them in this particular part of our research. So here's a vignette, and when it was presented to patient or consumers, the survey respondents, we randomly assigned whether or not that patient was described as white, black, or no race was attributed to the patient at all. Because we wanted to see if there was anything going on with the racial description of the patient in people's response. So here's the vignette for the PSA situation. A 55-year-old man goes to his doctor because he is having problems urinating. He tells his doctor that he wants to get the PSA blood test for prostate cancer. His doctor tells him that he has a very common problem and that he will do an examination. But he also tells the man that routine PSA tests are no longer recommended by a government task force and that he doesn't think it's necessary at this time. And then, please select the answer that best describes your opinion about what you think the patient should do. Let me give you the mammography vignette and then show you the answer. So in this case, we have a 45-year-old woman, again, randomly assigned if the woman is described as white, black, or no race. Just found out that her best friend was diagnosed with breast cancer. She immediately calls her doctor to get a referral for a mammogram. Her doctor tells her that based on her personal history, she's not at high risk for breast cancer and that a government task force no longer routinely recommends mammograms for women in their 40s. She can wait until she's 50 years old to get her first mammogram. Please tell us what you think best describes about what the patient should do. And here's the responses. One, trust the doctor and don't get the test. Sort of like, okay, doc, thanks for telling me what to do. Tell the doctor that he or she wants to go off and do his or her own research. Insist right there on getting the screening test. Have a discussion with the clinician, reach a joint decision, or other. I have to tell you, people, almost everyone picked one of those four and then wrote, you can't believe some of the stuff they wrote in other, especially on the mammogram one. But I want to know, sort of, what's your guess? Like, so what percent of patients in the PSA vignette do you think said, okay, I just will follow the recommendation of my doctor? And actually, we know on sort of the other side, when we want, when there's interventions to increase the use of clinical preventive services, recommendation from a provider turns out to be the strongest predictor as to whether or not a woman, is over 50 is going to get a mammogram or other sorts of adherence to guidelines. So we know that provider recommendation carries a lot of weight when you're telling patients some kind of behavior, positive behavior you want them to engage in. So just for fun, trust the doctor, not get the test. On the PSA side, what do you think? 50%? 40? 30, 20, we're going down. The opposite of an auction. Okay, how about on the mammography side? Someone say 0? 20? All right. So you think there's a difference in these two. PSA, 7% now again, this was men and women sort of responding about what they think this hypothetical patient should do. So about half said, want to have a discussion, reach a joint decision, but low there. For mammography, about the same. Only 9% said that, that woman should just trust the doctor and not get her mammogram. And again, Here it's a little bit lower, but about 44% wanted to have a discussion and reach a joint decision. If we put these two things next to each other in the pie chart, you see that, I mean, the distribution of responses is pretty similar. So again, the same people are answering both vignettes, and they're not sort of really, discerning between how they think that conversation should go for the female test versus the male test. Anybody want to venture a guess about the differences if you attribute race to the patient, white, black, or no race? So you think it would even be lower than this if the patient is attributed as being black? I've never seen anything with not, to the first decimal point, it was exactly the same. I even checked with the survey lab. Did you forget to randomize the patient attribution? And they assured me we didn't. And actually, if you went out to the second decimal point, it was different. But I mean, there was absolutely no effect in terms of how a patient was.
Was there an interaction with the respondent's race? Because you said you oversampled African Americans.
I didn't look at that unweighted. So then we oversampled for them, but then we put in the weights to sort of take care of that. But then we did some regression to see, what are the characteristics. So this is for the PSA vignette. What are the characteristics of respondents who endorse that joint decision? And here we found that people 60 years of age or older, respondents who are white, this is all about the respondents with less than a high school education, and respondents who had a more positive attitude towards research and the role of research in crafting guidelines. Were more likely to endorse a joint decision. Here's, I think, an interesting finding, that actually men were, the odds of a man saying that the patient should just trust the doctor and do what the doctor said and not get the test, almost 3 times. This is if the respondent was a female. So the men for the PSA test were much more likely to endorse, again, following what the doctor said. On the mammogram side, again, respondent characteristics associated with endorsing a joint decision, 50 years of age or older, white respondents, there's no gender effect here at all, less than high school education. We also controlled for whether or not people had internet at home. That seemed, because remember in this survey they give internet access to people who don't. Positive attitudes towards research. And the respondent characteristics associated with trusting the doctor, accepting the recommendation for this woman to not get a mammogram until she's 50. The only thing that turned up there was if the respondent had more positive attitudes towards research. All right, so that's the survey. Again, we had lots of variables, lots of descriptive sort of stuff. Not the most exciting kind of things came up. I'm the first one to admit it when we did all of our regression analysis, and I think it sort of means that across the board, I'd say there's really low levels of understanding of clinical preventive services and certainly of the Preventive Services Task Force and how guidelines are made, and you kind of see that across pretty much all socioeconomic, sociodemographic groups in the United States. So then we moved on to do an experiment based on the survey that we did and also that formative research that I alluded to before. And what we wanted to do, and again, this was an online, it was again using GFK, a different sample, because this got into the field about a year after the survey did. We wanted to test different message frames about the Preventive Services Task Force as a kind of expert guideline or an expert committee that makes guidelines. And we also wanted to test some message frames around the guidelines about not getting screening tests, things that are not recommended, including the PSA test. Here we moved from mammography for women in their 40s to the guideline, again, relatively recent change in guidelines that women don't need pap tests every year anymore. You might ask, why did we do this? We had, why didn't we stick with the mammography one? And we had a lot of conversations with our advisory board. I will say I finally cried uncle on that one. I've given up on, I just don't think public opinion's gonna change. And as many of you also know, Congress has intervened about, overriding the Affordable Care Act in terms of, what guidelines to use. It's all the most recent version of the Preventive Services Task Force guidelines, except for mammography for women in their 40s, because they don't like the most recent one, which gives it a C rating, and they want to go back to the one before that. So I just sort of gave up and said, let's see if we could learn anything about how to frame messages. And again, a lot of you are clinicians. I know in my own life, I have, just the other day, I had a couple people sort of yelling at me about why, shouldn't women still be getting their pap tests every year? I'm like, no, they actually don't need to get them every year. But that one's been kind of a hard sell in the general public as well. So, our goal here was to see if we could learn anything about, again, different ways to try to educate the public about the Preventive Services Task Force and its guidelines in a way that would inform future attempts to craft communication strategies. And also, again, I'll tell you that our advisory board had a lot of debate about, is our goal in this to help people who design communication interventions produce ones that increase the consideration of guidelines in personal care? Or do we actually want to increase behavior that's consistent with the PSA and PAP guidelines? I don't know how you are. I was always here, but again, having a board, an advisory board that's very patient-centric, all about patient engagement, they're like, well, if this is truly preference-sensitive care, it should be up to patients what they want to do or not, and your goal should just be to make sure they have all the information, but then whatever they decide, that's not a normative sort of thing. So again, I don't know how you all feel about it, but I think, I think there's a reason for the guidelines. I do think they're evidence-based. I think there can be some negative consequences of not following the guidelines, which you'll see in our communication strategies. So I'm okay with this. But again, I just wanted to let you know that actually was a big point of discussion among our research team and with our advisory board. Okay, so again, we used the knowledge panel, population-based sampled of the GFK. And the sample here for women, because we're going to be talking about pap test screening with them, was women 18 to 64 years old. And then on the PSA side, we sampled men 40 and older. I actually wanted to just do men 50 and older, but it was going to take us too long to get that sample just for men 50 and older. And so we went with 40 and older, but of course all of our analyses control for age. And again, we oversampled for people with with high school or less education, so less than a college education, African Americans and Hispanics. We got a little over 2001 people were sampled, and then again, sort of quit. Our goal here was to hit 2,200, and we went a little bit over that. And then for this particular study as well, we did a follow-up because you can, in a lot of these internet-based experiments, you expose people to some kind of, either a fake news article or some kind of text or some kind of communication exposure, and then usually they're asked questions immediately afterwards. What did you learn from that? What are your behavioral intentions? We did that, but then we wanted to follow up and see if there's any sort of sticking power to this, and if we still see differences. Maybe we see differences at the beginning, but do we see them 8 weeks later? So we followed up with people and resurveyed them 8 weeks later. So here's just a graphic of the study design, that everyone was randomly assigned to get one of 3 different sort of message frames, the men about PSA testing, the women about PAP testing, immediately after they were asked some questions, but then we followed back up with them 8 weeks later, and what was the response rate? About 75% for the follow-up, which for these kinds of things is pretty good. It's okay. All right. So what were we looking at? One is, and again, Doug Evans, who's on our research team, is a communications expert, and one thing we wanted to look at is, this is well validated sort of construct in communications research, is people's sort of receptivity to the message. So you give people a message and then you want to find out how receptive or open to that message were you, and that could be both a dependent variable itself, but then that message receptivity can also then be a predictor for other kinds of things that you're looking at. We also wanted to know then, did people seek more information on the internet about the test, either the PSA test or the PAP test? Did they also intend to speak with health professional about the test? And did they intend to speak with friends or family about the test? An 8-week follow-up, that's not long enough for us to get behaviors like, and actually we're interested in them not getting a test. But I mean, again, that's just not long enough to find out about actual use of testing. So again, this was really, it's preliminary research about receptivity to different message frames and then behavioral intentions primarily. The message receptivity measure is asking people, after they see a message, say, how much did that grab your attention? Did that give you a good reason to seek more information? Did it say something important to you? And again, this is a validated sort of approach in health communications research. Now, the message frames for, again, both on the PSA side and the PAP test side, were either, remember, randomly assigned people to one of 3 groups. So people either were randomly assigned to get a message frame that was a gain frame. Basically, if you follow the guidelines, there's going to be positive benefits. It's again, the gain frame. A third were randomly assigned to messages that had a loss frame. If you don't follow the guidelines, you might have some losses, some negative things might happen. There's downsides. And then also there was a third of the sample was exposed to a combination of both gain and loss frame messages. In health behavior research, this is a whopping generalization, and Professor Jans can correct me if she thinks this is a wrong generalization, but I think generally, if you're communicating with people about something you want them to do, rather in this case, it's about something not to do. When you're communicating and you want someone to engage in a behavior, most research has shown that the positive, the gain frame messages tend to be more effective. Would you agree with that in general? Okay. Of course, there's nothing in research that's 100% across everything, but sort of in general, especially on cancer screening. So again, we were interested, does that sort of apply when we're telling people not to, basically, we're telling them to follow a guideline, but following a guideline means don't get a certain kind of health care. And people got 3 messages, and then they were asked to kind of rate their receptivity to that cluster of messages, and then they got 3 more messages, and then 3 more messages, all in the gain frame. So here's 9 messages in the gain frame. Again, 3 clusters. Those were randomly assigned. The order kind of mixed things up. So I can't tell you if order matters or not, but at least we varied the order, so that shouldn't actually be a factor. And the loss frame, again, here's the messages. You wonder if you consider the best evidence. You worry that you'll get additional unnecessary tests if you get basically a false positive, an incorrect test result. You might have higher out-of-pocket costs. Your insurance premiums could be higher. So again, this is the loss frame. And then the combo frame took things from both the gain and the loss frames. Summary, high-level summary. So higher respondents, and again, it was separate analysis for the men and the women. because they were only exposed to the gender appropriate intervention. Higher reported receptivity to messages. So people reported that, again, with that receptivity scale, a higher level of receptivity, they actually were much more likely to then seek out information on the internet, and also to report an intention to speak to a healthcare professional about that particular preventive service. Or this is actually a combination of putting both of the genders together. Sorry about that. Because the same questions were asked in both things. So if you put them together, and actually there was no gender difference in that. Again, very high level summary. And this paper is already published if you want to go look at it and look at some more of the number results. But it turns out that the loss frame was associated with about a 50% increase in the odds of people reporting that they intended to talk to family and friends about both PSA and PAP tests compared to the positive frame. And we saw no other treatment condition. I have to say, this is my, got this big grant from PCORI. These are my two studies with not that many interesting statistically significant effects, I'll tell you. Basically, again, you can sit in your office and run regressions all day, and it's kind of frustrating when not that many things turn up to be statistically significant. But anyway, I think this is an important finding, that again, the loss frame, which is different, again, from prior literature, and especially if you look at the literature, I know the literature on mammography screening very well, and other kinds of cancer screening tests, it's generally felt that more gain frame messages are more compelling and motivating to people about getting a test. And so this could be, and this obviously needs to be tested more, it could be when you're communicating about behavior of not getting a test that loss frames might be more effective. All right, so let me give you a summary of the overall project findings. So we found there's low levels of knowledge among US adults about clinical preventive services in general, about guidelines for clinical preventive services, and about this body called the US Preventive Services Task Force. Not a surprise, but we can tell you what the population prevalence is of the low level of knowledge here. Also, people generally endorse that research in science and expert medical opinion are important for guidelines. However, only 1/3 trust that a government-sponsored task force is going to be making sound and fair decisions about guidelines. And also in the vignettes, less than 10% in a vignette for both mammography screening for women in their 40s and PSA screening believed that a guideline-based recommendation from a provider was sufficient in and of itself for patient decision-making. Crafting messages that consumers believe and find important and are receptive to them is associated with active information seeking and behavioral intentions, at least up to 8 weeks after they get exposed to those messages. And then contrary to other research regarding the promotion of cancer screening use, the loss frame might be more effective in promoting guidelines that recommend against screening. So what are the implications of all this? Again, there are growing movements in regard to both evidence-based medicine and patient engagement and active involvement in healthcare and healthcare decision-making. And as I opened up with, I do think this is particularly important when we're talking about those preference-sensitive kinds of healthcare, and clinical preventive services use is certainly one of those. However, less is more is a hard sell. I think it's a hard sell in general. It's also a hard sell when you're invoking a government-based, evidence-based task force in the general US population. But I think there's obviously room for more research to figure out how to better support and provide guidance for how some of those patient-provider discussions could go. And then finally, if we have time, I'm really be interested in some of your opinions about this. I think the U.S. Preventive Services Task Force, it's been around for a while. And with the Affordable Care Act, it is now reluctantly, but has been elevated, if you will, into the business of benefit design. There's no question about that. My opinion is I think it needs a good makeover. It definitely needs a PR person. And some of the timing, the release of some of the timing of their new recommendations has been just terrible. And how they release them, and there's really not much attention. I think they release them more for the provider and the research community than for the general public. But I think some of our work invokes some questions about, should consumers sit on the Preventive Services Task Force? Do you think that would be a good thing, or would that really sort of muck up a process that's supposed to be evidence-based, and that's really all that matters? Should experts in communications and decision science sit on or advise the task force? Because that doesn't happen too much. There's a lot of debate about this, and I happen to know that, and not so much at the Preventive Services Task Force, but some of these other bodies that are in the business of making guidelines and recommendations regarding clinical preventive services. There's more talk now than I've ever heard of before about really should cost effectiveness studies become part of the evidence? Should we just keep on, recommending things, and now that they have first dollar coverage, and not worry about the value that we're getting for that? Or should we just keep cost out of it, because that's really going to muck up and politicize even more than it is already some of these evidence-based recommendations? So again, we've got time for questions, and love to hear your musings on some of these issues. So thanks.
So if you were to frame it as a guideline from clinical experts rather than a government guideline, do you suspect that there should be more buy-in, or is that not going to move the needle much?
I think based on some of our survey results, I think it would help. I think there's a lot of mistrust of government. In hindsight, I actually wish that might have been something we randomly assigned, talking about a government task force versus other kinds of bodies. But so yeah, I think it might help. But I also think that is the difference between the Preventive Services Task Force and, let's say, the American Urological Association recommend. If you take professional association recommendations, some might argue there's a conflict of interest in there. So yeah, it's an empirical question. It's a great empirical question, and I don't really know. But I think there's a lot of, it's an election year, so I think there's even more mistrust of government right now. But I think there's mistrust of research to the point that it probably matters, but I'm not sure 100%. Dr. Fendrick.
I want to follow up on that. First of all, the U.S. Preventive Services Task Force goes out of its way to not say it's non-governmental. It's on their website, they say they're independent like 62 times. And I think that, to Joel's point, that isn't even correct literally in terms of steering people down that way, given that when I ask people about Section 2713 that legislated this, if you ask people, do you like low-cost or no-cost preventive services, and don't say it was mandated by the ACA, let alone the task force, 98% of people say they like it. And when I ask them that it's ACA mandated, it's 42-42 split along party lines. So the government thing, I think, is past. If you have asked them, which I know GFK does on occasion, their political leanings, I think that would have been really interesting, because the whole part about the way this was framed is, and having had so many experiences, you say this is related to the ACA, I hate it. No matter what it is. And I think that if you ask them where they got their news from, that's even, if they wouldn't tell you what party it was, I think all of these things would have been amazingly predicted. But the government thing, even though the task force is only, as they say, provided support from ARC and whatever, I think that it tells you, as your last comment says, this is an extraordinarily controversial issue that's political more so than policy. And you know better than anyone in the room the differences between. I try to say that, but that's. I think the politics really drove this, maybe much more so than you thought when you started.
Yeah, and this is being webcast, right? But I'm going to say something just in the room among us friends too. I think your funders can have an impact on how you shape research questions. So actually having PCORI be a funder here, and I think it's a legitimate question. What happens when you tell people the truth about it, right? So I mean, there can be all kinds of spin about it, but the U.S. Preventive Services Task Force, yes, it's funded by ARC. It's we can't say it's non-governmental, and what happens when you tell people this is try to explain to them this is what it is. It's based on evidence. It doesn't consider cost. Is that a non-starter? Can we be effective in communicating with people about a pretty complex sort of process? I think our results show it's super hard to be, communicative with people about this complex, situation and process. Larry.
So the other actor you don't really talk about at all here is the payer. Mm-hmm. Payers have incentives to providers to have them conform with a whole list of preventive and other services, or penalize them financially for not conforming, which I think supersedes some of these more theoretical concerns. And I think talking to patients about that inherent conflict would also be particularly interesting.
I will say then, when we were doing our formative, very preliminary sort of work and handing out boxes of chocolates and talking to providers, one thing we asked 175 non-random providers is what guidelines do you follow for your patients for mammography screening and for PSA screening? And at least half of them said, well, I follow the Preventive Services Task Force and the American Urological Association and the ACS. And then I started violating the rules of research because I should have just written down their responses. But after a few people saying that, I'm like, they disagree. Those guidelines disagree. And they would say, yeah, but I invoke the guidelines that help me convince the patient to do what I want him or her to do. So if I've got a guy who I don't think should get a PSA test, I'll invoke Preventive Services Task Force guidelines. If I've got a guy who I think should get a PSA test, I'll invoke the AUA guidelines. Lots of you are nodding, so maybe you do this in your own practice as well.
So, you could, part of it, you could read kind of positively. The fact that half of them say that you share decision making with their doctors, actually isn't too far off from what a lot of the recommendations at least have been recently. So
sure.
People have sort of learned, they may have learned something about shared decision making, and then the other thing is it's along the lines of kind of everyone hates Congress, but they like their congressman. You sort of this scenario where you have this kind of faceless doctor who's telling you to do something kind of has the tendency of kind of making you feel like, I don't want to be told what to do. But if it's your doctor who if they trust you, then it can be a different story in terms of how that may sort of reconcile some of the things we find when we do
sure.
actual surveys of actual practice versus these scenarios. But the question is whether you could actually find ways to do this. We have a big. We just got a large grant to try to develop, what we would call de-intensification measures, the things that should be de-intensified, some of which are related to this. But and as part of it, we've tried to build in this large piece where we have patient and provider groups to kind of provide some of the perspective of how these measures might end up getting implemented and what impact it would have on their daily workflows or the stuff that they're kind of all used to getting and not. And talking about it at patient. So I don't know if that's going to give some of the answers, but I think that's probably where a lot of the action has to happen. The flip side, which I was going to ask you about, is what the choosing wisely with this different route of kind of trying to get consumer union involved in sort of selling
consumer reports.
Yeah, right. So what do you know about? I haven't heard. I've seen a lot of provider side of choosing wisely, but I've heard nothing about what's happening on the consumer side. do you know anything about what they're actually doing, or there's any sense that that's been successful?
I mean, Consumer Reports does have an issue on which screening tests. Consumer Reports has taken this on.
Yeah, in an earlier version of our survey, we actually did want to ask, have you heard of the Choosing Wisely campaign?
Show them some of the stuff, material that,
Yeah.
oh, this is what Consumer Reports say, I mean, I'm interested.
Yeah, I don't know about that one. Thank you so much for your time and attention.